Welcome to Oncology Morning Commute, making the case for follicular lymphoma therapy. Morning Commute is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals Incorporated and Novartis Pharmaceuticals Corporation. In this podcast series, our faculty will discuss follicular lymphoma, its management, first, second, and third line treatments, including some of the newer therapies. For example, the PI3 kinase inhibitors, copanlisib and duvelisib, and the CAR T-cell inhibitors, including axi-cel, lisa-cel, and tisa-cel, as well as bispecific antibodies such as mosunetuzumab. In this episode, Dr. Christopher Flowers and Dr. Loretta Nastapil discuss the many factors that should be taken into account when selecting and sequencing follicular lymphoma therapy. Information about the faculty and disclosures can be found at morningcommutepodcast.com/FL4. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Flowers is a professor and ad interim division head in the Division of Cancer Medicine in the Department of Lymphoma Myeloma at the University of Texas MD Anderson Cancer Center in Houston. Dr. Nastapil is an associate professor also in the Department of Lymphoma Myeloma at the University of Texas MD Anderson Cancer Center, Houston. I am your host, Candace Hoffman. Dr. Flowers will begin our discussion.
Well, it's a pleasure to have you back, Dr. Nastapil, to talk more about follicular lymphoma and the various therapies. We'll talk now across the spectrum of therapies for follicular lymphoma. And we talked our last podcast about some of the challenges of sequencing therapy in follicular lymphoma. But as we think through that issue, how do you talk through that at the beginning with a patient with follicular lymphoma, knowing that this is a patient when they first get a diagnosis, may or may not need to start therapy, but the likelihood that over the lifetime of their disease, that they may need to have multiple lines of therapy? How do you prepare them for that potential outcome in the management of follicular lymphoma?
The analogy I use, which who knows how well it's received, but this is always a marathon, not a sprint. And so we always take into consideration where we start, how much progress we've made, both in terms of remission duration for the patient, but also how has the field evolved? There are new therapies that are entering into the treatment landscape nearly every year. So what I may have been excited about 5 years ago may be vastly different from what I'm excited about today or what I anticipate will be exciting in the next few years. And so at each time point when we're making a treatment decision, we take into account what their prior therapy has been, what their remission duration was, and what their goals of therapy for their next line of treatment is. I think some patients have clear life goals. Oftentimes, it may be that they need to get to retirement and they're willing to accept more intensive therapy now if it gives them a longer remission period, so then they can be less concerned about needing ongoing therapy when they're transitioning out of their workplace. It may be that they have, vigorous work schedules. And so how much time is spent in the clinic and how much of an impact on quality of life will result as of our choice of therapy. That always factors into our treatment decision. But I think it's hard not to lose sight of how much efficacy we've achieved with prior lines and whether or not we need to sort of improve that timeline. If I have a disease where they're starting to progress quickly through therapy, because we always set them up for the idea that they're going to do really well and they're going to have long remissions and there's going to be prolonged periods of time where they're not in our office. If that's not true, then that's going to likely impact my decision to pursue more intensive therapy or shift gears, for instance, while we're managing this disease. How do you discuss this with patients about the longevity of the disease balanced with the expectation they're going to relapse and have more than one course of therapy?
As a runner, I really like the analogy that you use, and that's one that I've commonly used. But I think that it is really important for patients to really understand that you're approaching the disease, one, in terms of what the pace of the disease is for any individual patient, and that therapy will be individualized. And then secondly, the patient really has a lot of input into the ways the treatment decisions that are made. As you said, many of the things that we have been excited about in follicular lymphoma change over time throughout a career. And, in my career, there were things that very early on I was very excited about in follicular lymphoma, like vaccine therapies that were tested and never really completely materialized, and other therapies like radioimmunotherapy that came and have gone from the management strategies of patients, and therapies that, 10 years ago when I was talking to patients, like CAR T-cell, that were never on the horizon and may be here to stay as kind of long-standing approaches that can become integrated into the management of the disease over the course. And so giving patients that perspective on the roles that clinical trials play in the management of a disease that's not considered curable, I think is important. I think the other thing that's important is to give patients a perspective on what incurable really means for follicular lymphoma. I think oftentimes when someone reads about the disease not being cured or curable, or patients having a disease with that diagnosis, they think about much more aggressive behaving cancers, things like pancreatic cancer or metastatic solid tumor cancer, where having a disease that's not curable means that you're going to have a much shortened life expectancy. And while that's true for a very small number of follicular lymphoma patients, for the vast majority of patients who have follicular lymphoma, if they do well within that first year or two of therapy, they're going to have a life expectancy that is really near normal for aged and matched controls. And so I think it's important to give them that perspective that while they may need to have therapy at various time points based on what the pace of the disease is, that they're likely going to live a very long period of time and have very favorable outcomes during the times that they're needing to have treatment, and some prolonged period of times when they won't need treatment. So as you take those kinds of factors into play, what are the things that help you to decide what first-line therapy to give for a patient with follicular lymphoma?
Generally speaking, I want to give them as long a remission period as possible. And I think why that's important to me is they've been diagnosed with cancer. Inevitably, that's going to shape or even shift their perspective on their life. And you can't help but know that mortality is going to come to the forefront of that concern or decisions that are going to be made. And so if I can put them through therapy that's going to be tolerable, but also result in a long first remission, it always makes the discussion about the next line of therapy a lot easier. And so I'm generally going to reach for that chemoimmunotherapy because, in my opinion, I think that probably is going to give them one of the longest remission durations. And I'll mention some of the caveats or specific populations where that's not true. I have a long discussion about why I would choose bendamustine, for instance, over a CHOP-based backbone, and whether or not I would replace rituximab with obinutuzumab, for instance. I do that because my second line approach most commonly right now is going to be lenalidomide and rituximab. So I think that lends itself well to that next sort of best line of therapy I can offer to give them another sort of prolonged period of time where they might be in remission. And then whenever I get to third line, usually at that point, it's, what is the most interesting aspect in terms of trials that are available or mechanism of action, and what was the outcome of the last two treatment decisions I made, and where do I need to pivot? Where do I need to stay the course? Where that's not necessarily true is if I have a patient who's frailer or who has comorbidities where a chemotherapy backbone is not particularly of interest, then I might use lenalidomide and rituximab frontline. And there is data that even for older patients over 70, the toxicity profile of lenalidomide and rituximab looks to be quite manageable, particularly if you do dose adjustment for the lenalidomide dose based off of creatinine clearance. So that might be a consideration for an older patient. I may even lead in with rituximab alone. And then at the first response assessment, which I usually do about 3 months in, I can decide at that point, do I need to add in more therapy, or did I get enough benefit out of 4 weekly doses of rituximab? So I do think there are characteristics that do factor into how aggressive I'm going to be in frontline, but I do want to try and give them a deep remission. My goal is complete response. I want that to last a long time so that they could potentially even forget about this for a period of time, and then I'm going to follow that with my next best thing.
I will say I completely agree with you on all those points. I think trying to get a good and very prolonged response to first-line therapy offers a very meaningful benefit to patients with follicular lymphoma, in my experience. I will also say is that with a chemoimmunotherapy regimen, I would say more often than not, patients are surprised by how well they tolerate that compared to how well they thought they might tolerate chemotherapy from the beginning. One of the things that I often say is that as we give more cycles of chemotherapy, we expect that the toxicities are going to get worse and worse and worse over time because each of those chemotherapy regimens compounds upon the last one in terms of expected cumulative toxicity. But what I've actually found in practice, and I see that most of my patients see, is that each regimen actually oftentimes gets better and better because they have a better perception of how to deal with those toxicities and manage them through time. And while we expect theoretically for them to get worse, in practice, they typically are able to manage those quite a bit better. I will say that there are some practitioners out there that use quite a very different approach to follicular lymphoma and think about it as a disease that's not curable. And so take approaches that are not targeted with curative intent or prolonged remission intent. And so tend to use the simplest and best tolerated regimens first. And that typically involves a regimen like single agent anti-CD20 antibody as a first therapy. And then when patients relapse, to give another single agent anti-CD20 antibody therapy. And then when patients relapse again, to try and do that again until that no longer is effective, and then move on to a chemoimmunotherapy regimen. I think that is an approach that I've seen out there on many occasions. It's typically not the approach that I take, and one that both clinicians and patients seem to choose on occasion. But I think that is part of that patient-physician discussion that needs to take place about how the approach to the disease should be utilized.
I think you raised some really important points that I'm just sitting here pondering, thinking, why would there be so vastly different approach and that still be reasonable? And I think one of the things that I think about is that patients with follicular lymphoma, the disease responds quite well to just about anything that we do. And so are there strategies that we can explore to try and minimize the decisions that need to be made and inform sort of best practices? And so where we're lacking and why there's so many different approaches that actually do make sense is we don't really have good predictive biomarkers that help us navigate these various options and use patient-specific or tumor-specific features to say, this is actually the preferred treatment for you, and it's going to result in X amount of remission, and it's better than this other option for these reasons. Do you foresee anything on the horizon that might help inform that discussion a little bit better?
So I think we're starting to move in the right directions to be able to address that. One of the things that we've seen in terms of what we know about biomarkers over time with follicular lymphoma is unlike other cancers that we've seen, like breast cancer or lung cancer, or even in some cases, some other types of lymphomas, where the genetic profile of the tumor itself matters most in terms of how things respond and how durable those responses. That's been relatively less true with follicular lymphoma. And what may matter more is how the tumor microenvironment, or those immune cells that are around the follicular lymphoma, what do those look like, and how does that affect the way that follicular lymphoma will respond to therapy? As we refine that understanding, I'm hopeful that we will identify predictive factors for specific therapies, particularly as we start to develop more immunotherapy-based approaches, considering that rituximab is an immunotherapy-based approach. And so CD20 targeting is one of those, but there now are many, many others that are emerging, including those in later lines of therapy, like CAR T-cell therapy, that are directly focused on bringing the immune system, and even therapies that we're testing in clinical trials like bispecific antibodies. And so as we know that follicular lymphoma is a disease that responses depend upon the immune system, we may have better predictive biomarkers as we turn towards therapies that are more immune system based. So I am hopeful in that regard. I think the other thing that as we deal with the numbers of treatment approaches that we use in follicular lymphoma currently is to gain better understanding of the sequence of therapy and how sequencing of therapy impacts outcomes overall, not just looking at one particular line of therapy, but a whole host of lines. And we now, through large-scale observational studies, are starting to gain those kinds of data around sequence of therapy that may help to inform our choices over time. So as you think through kind of maybe those two major scenarios that we talked about, the kind of approach of giving a long remission with the first line of therapy with chemoimmunotherapy, or the kind of approach where someone is giving single agent rituximab as the least intensive therapy, how do you use those to think through what do you do in the second line and later lines of therapy?
A really important aspect to consider, I think, depends on how much tumor I'm dealing with and what their remission duration was following their last treatment and how intensive was that therapy. So I actually do quite a bit of single agent rituximab for patients who have primarily bone marrow involvement and cytopenias that warrant treatment, but I may not necessarily want to use bendamustine, for instance, in that situation. I may do single agent rituximab. And if they get several year remission out of that, I may consider rituximab alone again at that retreatment time period. That I would say is a less common scenario, but something now that I'm reflecting on, well, what do I actually do versus what do I say I do? I do have those patients where I have pursued single agent rituximab a few times and they've actually done quite well. So you mentioned the pace or the tempo of the disease, that clearly factors into my decision. Comorbidities, again, how likely are they going to tolerate more intensive therapies? In some ways, it gets harder as we get into later lines just because the options expand. And so there are more therapies to consider in terms of preferred mechanism of action, preferred length of therapy, toxicity profile. How does that factor in? And so it does get harder to walk patients through all of the options, but I'm generally approaching this from as much as I can garner from a disease biology standpoint. So I utilize things like PET-SUV, I utilize LDH, I consider B symptoms, I consider the amount of tumor that's accumulated over what period of time. Those are all the factors that I consider when I decide, well, how intensive do I need to be with that next line of therapy? And particularly for those folks that I've started gentle, if I need to escalate because things are, growing quickly and all of those other factors are getting significantly worse, I'm going to come at this much more intensively. And the flip side of that coin, if I started more intensively at frontline, they had chemoimmunotherapy, they're relapsing in second line, it's been a long remission duration, they've got lymphoma, but it's not a dramatic amount, I may go gentler in that second line. And so I do think what happened before and what is the outcome of that prior decision clearly impacts my next choice.
So you talked through a number of scenarios for our patients with follicular lymphoma, and the ways that you describe it, it sounds like there's not one right choice that works for all patients with follicular lymphoma. Are there any scenarios where you can describe where there might be a wrong choice, where there are certain regimens that you would say that may not be the most appropriate for a patient in a particular setting?
There are some things that I've seen that I would have done things differently. I don't know, again, who could be the judge of whether it was right or wrong. What I don't love to see is when patients will have bendamustine rituximab frontline and then they relapse and then they get bendamustine based approach again in that second line. I hear lots of discussions about, well, how long the remission period was and whether or not, it was a reasonable time frame and you want to retreat. My bias is those patients generally have cytopenias that don't recover very well. The bone marrow clearly takes a hit. Then they're at risk for infection. And then I struggle to find that next line of therapy that I can safely administer when they have profound cytopenia. So that's something, given the list of options that exist, I generally don't retreat with bendamustine, and particularly not within a short period of time. I think for patients who have significant cytopenias and renal insufficiency, you definitely have to be careful with lenalidomide in that setting, particularly if you don't get aggressive about dose reduction of lenalidomide, because they're going to have cytopenias. And particularly, again, if we're dosing at a much higher level than should be done in the setting of renal insufficiency. Same goes for bendamustine. You got to be careful with significant renal insufficiency and not appropriately dose adjusting or using an alternative choice. I think for the PI3 kinase inhibitors, for instance, copanlisib, if I have a patient who's borderline diabetic and I don't counsel them well enough, they're likely going to have hyperglycemia with copanlisib. And so you just need to be sure that you're appropriately setting them up for success, making sure they know what we're watching for, how to adjust diet, and how to monitor for hyperglycemia. So there are settings where if there are lots of options available, I might question why one path was chosen. And I guess the last thing I'll say, for instance, the BTK inhibitors, ibrutinib in follicular lymphoma hasn't had much efficacy. I'd say it's happening less often now, but years ago, I used to see quite a few patients getting ibrutinib as that third line choice, which again, at least based off of the data to date, that hasn't been an attractive option amongst all the other options. What would you say is a wrong choice? That's kind of a hard question to answer.
Yeah, and that's why I asked it, but I think you answered it very well. I would completely agree with all the points that you made. I would say, in general, what we've seen for the BTK inhibitors, they have not had great responses with ibrutinib, and I agree with you there. There are new data coming out on zanubrutinib that raise that as a potential option, and I think we'll need to see kind of how those data mature to see whether that as a different BTK inhibitor has activity compared to what we've seen with ibrutinib. One of the other points that you made earlier that really goes without saying, in patients who have significant cardiovascular disease or have had prior anthracycline therapy, reusing anthracycline therapy in patients with follicular lymphoma is something else that I also would avoid. The other population that I would add to copanlisib are those patients who have hypertension, where you can see infusion-related hypertension that can be exacerbated by copanlisib, and I would tend to avoid those patients who have uncontrolled hypertension from utilizing that agent. And then maybe one other that I would add to your list are patients who have high tumor burden that you described, particularly with high SUV, but also those patients who have isolated high LDH, considering the use of single agent rituximab. We know from older studies that when single agent rituximab was used with high LDH, that progression-free survival tends to be relatively short. And so talking to patients and expecting to have the same benefits that you typically would see with single agent rituximab really may not hold quite as true for those patients as well. And so I tend to avoid it in that particular scenario. This has been a really exciting discussion about the challenges in managing patients with follicular lymphoma. I think hopefully you also took away from this how much fun it can be in taking care of patients with follicular lymphoma, given the variety of options that we have for patients and the opportunities to be able to interact and to be able to tailor each treatment selection to the patient's needs and to what they've had in prior lines of therapy, and to really provide that personalized care that all of us as oncologists really take pride in providing to each of our patients. I look forward to talking to you again in our next podcast 5, where we'll talk more about toxicities associated with each of the late agents that we described in the third and later line of therapy. And we'll see you again in our next podcast. Thanks, Dr. Nastapol.
Thank you.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/FL4. Look for all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.